here, so I have to be careful what I say. All right, guys, welcome back. For the next two talks, we're going to be talking about lymphoma in cats, so shifting gears a little bit. The first one we'll be talking about gastrointestinal lymphoma, both high-grade, low-grade, and inflammatory bowel disease, and we'll also be doing the non-gastrointestinal lymphomas in the next hour. So this one's usually fun to do right after lunch because we'll be talking about vomiting and diarrhea in cats, and that's always, but we're veterinarians, right? We have this discussion at lunch as well, so it's okay. So before we talk about that, let's kind of go a little bit sort of 30,000-foot view. We're going to go a little bit more global. Let's talk about chronic small bowel disease in cats. And I mentioned this yesterday as well, is that vomiting and these symptoms are often considered normal by pet owners and often by veterinarians as well. And so we get a lot of excuses from owners about why cats vomit. He just eats fast. He's always done this. He has a sensitive stomach. She's just a nervous cat, and that's why she vomits. She gets hairballs. And so again, I think a lot of the times pet owners often accept vomiting somewhat normal in many cats, especially cats with a long coat. So there was a good study that came out in 2013 that looked at inflammatory bowel disease, and there's this new terminology that we'll go through, EATL type 2, which is basically low-grade or small cell lymphoma. And we're going to unpack this in the next talk, or in this talk. Where they talked about the association of clinical signs in cats that either had low-grade lymphoma or inflammatory bowel disease. And so to be included in the study, the cats had to have one or more vomiting greater than 2 times a month for 3 months minimum, several weeks of small bowel diarrhea, weight loss of more than half a kg in the last 6 months, and they could have any combination of those as well. Then it was recommended that they have an abdominal ultrasound, and on ultrasound, if they had thickened small bowel in 2 locations greater than 0.28 millimeters, they were then included in the study. So again, they had to have these clinical signs, then they had an ultrasound, but then to actually really be included in the study, they had to go on and have surgery. So if an owner elected not to do surgery, they were excluded from their cat, from the study. And there were 65 cats excluded. 100 cats went to surgery, and 26 cats were just there getting a routine exam, and the clinician, was going over this. So they weren't coming in for vomiting, they weren't coming in for diarrhea, but the clinician was talking to them, and they said, this is not normal. Let's do an ultrasound, and then they went on to surgery. Again, 65 cats did not go to surgery and were excluded from the study. So what did they see? They saw that weight loss was the most common presenting complaint, vomiting was second most common, then diarrhea was the least common. And about 13% of cats had vomiting and diarrhea as their clinical signs. 92% had one ultrasound measurement, so I told you the cutoff was greater than 0.28, of greater than 0.3 centimeters. 99 of the 100 cats had low-grade lymphoma or inflammatory bowel disease. So there was only one normal cat out of 100 kitties. So 49% of the cats had inflammatory bowel disease, often called chronic enteritis, and 46% of the cats had lymphoma. The majority of them were T-cell lymphomas, low-grade lymphomas. Again, that's what the EATL type 2. Usually I'll have both terms for that because most of us are not used to thinking about it in those terms. And then 2% of the cats were B-cell lymphoma, a large and a small cell lymphoma. So again, 99 of the 100 kitties had disease. The cats that were less than 8 years of age ended up having enteritis, inflammatory bowel disease. Cats that were older than 8 had one or the other, so they either had lymphoma or enteritis. The one cat that was normal was a young kitty. He was only 5 years old. The disease was very segmental, and I think that's an important thing to think about when we're thinking about low-grade lymphoma and inflammatory bowel disease. So especially if you're doing endoscopy or some other procedure like that, or even if you're doing an Explorer, you need to really look at all of the intestines because some areas will look normal and some areas will be thickened and affected. So cats with clinical signs are quite common, and I really think it's important that we get a good history and recommend diagnostics. And important to stop making excuses. Vomiting is not normal, especially the frequency that we're talking about. And clinical signs should really trigger an ultrasound. We should be looking for those thickened areas of intestines, and then we should, consider surgery in those cases. One of the things that often gets up is vomiting hairballs normal, right? Especially these cats that have long hair and they're vomiting quite frequently. And they talked about this in this Norway study where they said maybe having chronic small bowel disease predisposes these cats to vomiting and not being able to process the long hair. If they had normal intestines, they probably, maybe they wouldn't be vomiting. So again, really kind of sort of making us think about the idea that vomiting hairballs is a normal thing just for long-haired cats. And so again, I think we need to stop making excuses for cats with vomiting. I'm going to skip over this because as we talked about, you've been with me for 8 talks. All right, so key points with lymphoma in cats. Just as in dogs, it's one of the most common cancers that we see, estimated to be about 30%. It's a systemic disease, just as in dogs, so it requires chemotherapy in almost all of the cases. We know that cats that are treated live longer and live well, just like we talked about with dogs. The problem with cats versus dogs is that cats are a little bit less predictable with their response rates to chemotherapy than dogs. But they tolerate chemotherapy better than dogs, so they tend to have less side effects. And as I mentioned, the outcomes are a little less predictable, and we're going to go through that in the next 2 talks. And the prognosis for gastrointestinal lymphoma, especially when we start clumping large and small cell, which many of the papers do, it becomes a little bit more difficult to give a good prognosis for owners, which is different than dogs. So just as we talked about with dogs, it's a collection of cancers arising from the malignant transformation of lymphocytes. Again, I usually tell owners that this is a cancer of one of the white blood cells called the lymphocytes. Very different in cats than dogs. We tend not to see peripheral lymph node lymphoma in kitties. The gastrointestinal tract is the most common location, and then in the next talk we'll talk about some of the non-gastrointestinal tract ones. Okay, so this is our roadmap: when, why, who, a constant theme. Then we'll talk about diagnostics, and then we'll finish up with treatment and prognosis. Okay. So, before 1990, there was a lot more feline leukemia virus positive kitties, and lymphoma accounted for 50 to 90% of all the hematopoietic tumors. Post-1990, the post-FELV era, there was a dramatic decline in feline leukemia-associated lymphoma, and really changed the pattern of lymphoma that we were seeing in cats. So due to diagnostic assays, catteries, being very judicious about eliminating as much as we could feline leukemia from the cat population, we saw less feline leukemia-associated lymphoma, but we actually saw an increase in the GI form since the post-1990s. So again, in the earlier years, 2/3 of lymphoma was associated with the feline leukemia antigen positive kitties. Being FELV positive increases the likelihood of developing lymphoma by over 60%, 60 times. So quite a dramatic increase. We tend to see FELV-associated lymphoma in younger cats. We tend to see the mediastinal form, and we tend to see T-cell lymphoma is the immunophenotype for those. Why? The virus has a direct role in tumorigenesis in these kitties. FIV can also increase lymphoma but less, by 5 to 6 times more likely. That's an indirect role in tumorigenesis, and usually due to the immunosuppressive effects, and we've talked about how important the immune system is, right, in cancer development. These cats tend to have B-cell lymphomas, usually is extranodal. If you have a cat, and has anyone seen a cat that's FELV and FIV positive? I have. And it's the double whammy, increases the likelihood of developing lymphoma by 77-fold. So quite a dramatic increase. But luckily, and I'm still seeing, the occasional feline leukemia positive kitties in practice, unfortunately. So what are some of the other causes? Immunosuppression. So we've talked about, that being immunosuppressed can lead to cancer. We know that cats that are FIV positive are immunocompromised, 5 to 6 more times likely to get it. Cats that get renal transplants or in chronic immunosuppressive therapy, 10% of those cats are likely to develop lymphoma. So again, just really highlighting the importance of the immune system. I tell them not to smoke, but some of the cats just don't listen. So environmental causes, there's a study that shows that cats that are in a home with a smoker increases the likelihood of lymphoma about 2.5 to 3-fold. So that's that's something that we can control and talk to owners about. And so, I mentioned to you guys that I do Facebook, and what was interesting to me is, in general, my dog posts are more popular than my cat posts. This was one of the most popular posts that I had this year so far. So every month I do these themes, and we did dog lymphoma in January, and in February we did cat lymphoma. And this one, and this was roughly a couple weeks after the post, This reached 20,000 people and was shared 158 times. So something about this pet owners and the veterinary community really thought was really interesting, and owners were very interested in this. And it kind of surprised me because, again, like I said, usually just not as popular. But again, something about this really resonated with pet owners. And this whole cat one was, really quite popular with pet owners online. So I thought that that was interesting. So owners care about why their pets are getting cancer, things that we can do to prevent it, and ways to treat it as well. Okay, so what are some of the other causes? We know that chronic inflammation, talked about using anti-inflammatories and other medications as anti-inflammatories, but it's thought that there's a role of chronic inflammation. So again, cats with inflammatory bowel disease can transform and become low-grade lymphoma. One of the other cancers that has been looked at is chronic rhinitis, leading to nasal cancers as well. People have always trying to figure out, is it something in the food? Is it the diet that we're feeding? There has been diet changes. A lot of the diets over the last 20 years in veterinary medicine have been adjusted for the prevalence of urinary tract stones and things like that. And then people have, wondered maybe that has been associated with the increase in gastrointestinal lymphoma. We're always looking at genetic, molecular factors, tumor suppressor genes, oncogenes, haven't definitively been worked out, but again, because of some of the breeds that are predisposed, that's one of the things that is being looked at. Okay, so why do cats get inflammatory bowel disease? So, usually it's a combination of the immune system. We talked about immunosuppression, diet, environment can play a role, genetics, and then we talked about the importance of the biome in the last lecture as well. And so again, when we think about treating cats with inflammatory bowel disease and remembering lots of our cats with low-grade lymphoma have concurrent inflammatory bowel disease, supporting the intestinal microbiome with probiotics, I think, is an important approach as well. So who gets lymphoma? Any age, any gender, any breed. Usually are middle-aged and older kitties, so 12 to 13 years of age. Males are predisposed. Some of these breeds are overrepresented in some studies as well. So where do they get it? Intestinal is the most common location. Sometimes they'll have mesenteric lymph node involvement and liver involvement as well. It can be solitary. More commonly, it's going to be diffuse throughout the gastrointestinal tract and segmental, as we talked about in that study. 55% of cats that have gastrointestinal cancer, it's going to be lymphoma. It's more common in the small intestine than the large intestine, and the location will really vary. So again, the FELV positive kitties tend to have bone marrow or mediastinal involvement, which is different than our FELV negative kitties. So there's this new terminology that I don't really love, but I didn't make it up, but I've seen it start to appear in the literature. And this is based on the World Health Organization for people. So enteropathy-associated T-cell lymphoma, EATL. And then there's type 1 and type 2. So type 1 is the high-grade lymphoma. These are the kitties that are getting sick more quickly. Their symptoms or clinical signs are coming on more quickly, and they are diagnosed with high-grade lymphoma, lymphoblastic, large lymphoma cells on histology or cytology. These kitties typically have a palpable mass. You can have B-cell lymphoma in the GI tract, but T-cell is more common, hence the name EATL type 1. Type 2 are our low grade. So these are the kitties like in the study that we talked about. Their signs are more chronic, more slowly developing. They have small cell lymphoma, so they're lymphocytic. And it's really hard on cytology, often for pathologists, to call whether it's lymphoma or some sort of reactive inflammatory process because they're lymphocytic, not lymphoblastic. And again, tends to be T-cell more common, but B-cell is possible. So what do we see? Just as within the study, vomiting, diarrhea, weight loss, poor appetite. Rarely kitties with low-grade lymphoma are icterus. It's going to be more common with the kitties with high-grade lymphoma. Usually this is a chronic disease. This is something on average has been going on for about 6 months. They usually will have an abnormal abdominal palpation, but it's not a big mass. It's usually just thickened, ropey intestines, as we say. But they can have a normal abdominal palpation as well. They can have a palpable mass in about a third of the time, but in general, again, it's more of a diffuse disease. All right, how does that compare to our kitties with high-grade lymphoma? Similar signs, more likely icteric. So again, vomiting, diarrhea, weight loss are the most common things. But it's usually more quick in onset. So these kitties are getting sicker quicker. So usually within days to weeks. A palpable mass is more common on their physical exam, and occasionally they actually come in with a septic abdomen, because because the mass is growing and is eaten through all the layers of the bowel, and those are the kiddies that need to go to surgery for their septic abdomen. Uncommon, but possible. All right, so what tests should we be doing on these cases? And so I'm gonna try to break it into the high grade and the low grade. For the high grade ones, they're usually much easier to diagnose. They come in, again, their symptoms are usually more quick in onset, usually feel a mass. We do an abdominal ultrasound, usually able for the internist or you or a radiologist to aspirate the bowel mass or a big lymph node. And usually cytology is going to give us a diagnosis. Usually much easier to make a diagnosis than these guys. Typically not going to surgery. The ones that are really frustrating and harder to make a diagnosis are the low-grade ones. And those, again, they might have thickened bowel, they might not. They don't usually have a mass. And it's very similar to inflammatory bowel disease. And this is really the struggle in practice, is trying to figure out, often do these kiddies have inflammatory bowel disease or do these kiddies have low-grade lymphoma? Cytology, remember I told you the cells are little lymphocytes. It's usually hard to make a diagnosis on cytology that it's cancer. And so typically these kiddies end up not only with an ultrasound, but they need some sort of histopathology, whether it's endoscopy, whether it's laparoscopy, like we did with Jeter, my kitty, or they go to surgery and get an exploratory. In private practice, most of the time, we're doing exploratories. Most vets do it very quick, GI exploratory surgery. So we're going to run blood work on these kiddies. It's not uncommon for them to be anemic, panhyperproteinemic, right? A lot of these kiddies are losing albumin and globulin through their diseased intestinal tract. We want to test them for feline leukemia and FIV. Pretty uncommon, still seeing it in the States, but again, FELV, not only does it increase the likelihood, but FELV kiddies don't respond as well to chemo, so I like to have that important information when I'm giving the owners the prognosis. Often I like to do what we in the States, it's called a maldigestion profile, and that's going to help us look for low B12 levels, so hypocobalaminemia, and folate levels. And we'll come back to that. And again, the ultrasound. So again, those kiddies that are showing clinical signs should really be a good trigger for an ultrasound to look for thickened intestines. Okay, what are the other things that we see? So the internist or the radiologist or you are going to be looking for wall thickness, wall layering. Is the motility impaired? Is there free fluid in the abdomen? Are there any big lymph nodes in the abdomen, so mesenteric lymph nodes? And again, how is the disease? Is it focal, is it multifocal, or is it diffuse? And again, thinking about if I'm going to recommend endoscopy, is it in the stomach or upper small intestines? Because if not, endoscopy is not going to be a good way to get a diagnosis. So is it accessible with an endoscope? That's the other thing that we're thinking about as we're getting our ultrasound report. And again, one of the big questions is, what test can I use to figure out is this low-grade lymphoma or inflammatory bowel disease? So for our low-grade lymphoma kiddies, again, they often have an abnormal ultrasound. They usually have thickened small intestines. About half of them will have big lymph nodes, and focal GI masses are uncommon. Okay, how is that going to compare? Is my ultrasound going to be able to tell me whether it's inflammatory bowel disease? They're really similar. Everything's a little less likely, so they're less likely to have the intestinal thickening, less likely to have lymph nodes, but they can be very similar. So ultrasound's good to let me know that something is wrong, but it's not going to be a way to make a diagnosis. You need to go on and get some cells. So other things, so cytology, like I mentioned, usually is going to be diagnostic for our high-grade lymphoblastic big cell lymphomas. But again, for these small cell ones, it's usually inconclusive and they just think it's reactive or benign hyperplastic. Pleural fluid, you could run it on that, but again, usually not going to be a way to get the diagnosis. Usually you need to go to intestinal biopsies, and I mentioned the different ways that we can get that done. Usually we're going to just evaluate the biopsies with good old histopathology, so H&E staining. We usually don't need to do special staining in most of our cats with lymphoma. Very different than dogs, where I talked about how B versus T is so important in prognosis, less important in cats. So until there's really good studies that show it should be changing how I treat or the prognosis, I do not routinely do immunohistochemistry for cats unless the histopathology was not conclusive. Then I might do it to see if they can highlight those cells. Okay, big difference from dogs. PAR is going to be another thing that I'll do. Again, only if my histopathology was inconclusive and we're trying to confirm the diagnosis will I add on PAR. I don't find out if most of my kiddies are B versus T cell. So again, H&E stain is a regular stain. There are things that the pathologist will look at to figure out, according to the WSAVA group, of whether or not it's IBD versus lymphoma. Immunohistochemistry, like I mentioned, I will only do if the H&E stain was inconclusive, and the same thing for the PAR. So most of our cases, you just need routine histopathology for your diagnosis. Okay? All right. So to summarize, for the high-grade lymphomas, much more straightforward. They come in, they're sick, they get an ultrasound. You can usually do ultrasound-guided aspirates. Cytology is usually going to be conclusive. Usually don't need surgery. Again, for the low-grade ones, those are the challenging ones to figure out is this IBD or not. Usually cytology is not conclusive, and you usually need some form of histopathology, whether it's full explore, laparoscopy, or endoscopy. With endoscopy, one of the big questions about it is whether or not, so the problem is it's not full thickness biopsies. And so if we do endoscopy and it says inflammatory bowel disease, I worry about whether or not we missed it because we didn't get full thickness biopsies. If I get lymphoma on endoscopy, I usually believe it, but again, that is the concern, is you're not getting full thickness biopsies. I have found that if I put gastrointestinal specialists in the room, I kind of get a split as to whether or not they like endoscopy or not. But in general, I prefer full thickness biopsies. Again, and these are the different things, the different characteristics that they're looking at to make a diagnosis of lymphoma versus inflammatory bowel disease. Again, if the diagnosis is equivocal based on my histology, then I will be adding the phenotype of the PAR. Do I need to do radiographs in an average kitty with gastrointestinal lymphoma? In general, no. As you guys have gotten the impression, I like to be practical. This would be a case that I wanted to do, and this is Jojo, and Jojo will come up in the second talk as well. But Jojo came in and obviously was coughing and had a lot of pleural fluid, so this would be a cat that we would want to do, this is Jojo, that we would want to do chest radiographs. But most of the kitties, if they come in and I'm working on a budget for gastrointestinal lymphoma, I'm fine to skip the chest radiographs. So the ones that have the mediastinal form, which tends to be more common in the younger FELV positive kitties, those are the ones that typically will do chest radiographs because they typically have pleural fluid. And again, it tends to be younger kitties, and we'll talk about this in the next lecture as well. Okay, so we've made our diagnosis, now we need to figure out how to treat. And so this isn't, again, I keep highlighting the difference between dogs and cats, but there's less data with the feline lymphoma forms, and often a lot of the papers will clump the high grade and the low grade together. So it makes prognosticating for owners a little bit more challenging than it is for dogs. You know, for dogs, they say, give them a CHOP chemotherapy protocol, 80 to 90% will go into remission. And with cats, it's just a little bit less predictable, and again, there's lots of sort of mixed groups, and when you start looking at the studies. Some of the newer studies are being more careful with just looking at high-grade, GI lymphoma, but a lot of the older papers had a bigger mix. So again, there's lots of different forms, which makes the outcomes less predictable, and there's more variation when you're talking to owners. One thing I'm very comfortable saying is cats tolerate chemo better than dogs. So that's one thing that we know for sure. And like I mentioned in the last lecture, febrile neutropenia, those side effects are very uncommon in cats. Most owners, just as in the dogs, are very happy that they choose to treat. Again, I think having that discussion with them, but again, most of the clients that choose to treat are happy that they did. Their quality of life improves and they live statistically longer, as we'll go through. Okay, so side effects, rare overall, we talked about this morning, but important to be very proactive in our cats, right? Their symptoms from their cancer, their clinical signs are the same side effects that chemotherapy can cause. So again, we want to be very proactive with our nausea medications, with our appetite stimulants. We talked about this morning, so I don't need to go through it as much. But again, these are kitties that we need to be very proactive with their appetites. You can use Entice off-label. It's 3 mg per kg daily in dogs, and in cats, the recommended off-label dose is 2 mg per kg. I know you guys don't have it yet, but hopefully you will. But again, we want to be very proactive, give them their information sheets, educate them about nausea. Again, I find especially if they're in multi-cat households, using Jeter, my kitty as an example, can be very hard to figure out who's eating the food. So just as in dogs, there's lots of different protocols. I'm going to try to break it down for you. A little bit more straightforward in cats with high-grade lymphoma, but there's no standard of care. In general, the overall response rate is about 50 to 80%, so a little bit lower than dogs. Most of the time, the first remission is about 4 months. So again, half the cats will do better than that, half the cats will do worse. Median survival about 6 months. So again, not as good as dogs with lymphoma. Cats that go into a complete remission is so important. Those are the long-term survivors. Where the median survival time is a year, and about 25% of the cats are at 2 years. Depending on what study you look at, only 10 to 50 to 60% of cats achieve complete remission. But those cats that can achieve complete remission, those are the cats that are going to be the long-term survivors. Another big debate, and we talked about this yesterday, is do they need a maintenance protocol? And in dogs, it's pretty much the standard that it's thought that they do not need a maintenance protocol. In cats, little less, as you would expect from the theme that I keep saying, we're still not quite sure, but most of the protocols are not using a maintenance protocol, but again, that's based on dog data, less data in cats. So in general, my favorite protocol for cats is going to be a CHOP multi-agent protocol, just as we did in dogs. I use the University of Wisconsin-Madison 25-week protocol, weekly for about 8 to 9 weeks, and then every other week. So it takes 6 months to finish the protocol. There are other multi-agent protocols as well. Again, response rates of about 45 to 75%, not as great as dogs. I'll use this for any anatomic location for high-grade lymphoma. So renal lymphoma, hepatic lymphoma, CHOP is going to be my first protocol that I pick. Very well tolerated. Again, many of the studies combine lots of different anatomic forms, so it could make tweaking out which ones do better a little bit hard. There are some newer studies looking at CHOP for just GI lymphoma, which is nice. COP is another alternative. So COP just takes out doxorubicin, that's the H based on the chemical name. Complete remission rates about 50 to 70%. This is often used in Europe, and some of the studies in Europe show comparable survival times to using the CHOP in the US. There's another paper that says the doxorubicin in that protocol is really, really important to long-term survival. So it's a little bit gray with what's, quote unquote, the best protocol. We talked about it with Jackie yesterday. It's weekly for 4 weeks, but then it's a long maintenance one where they get chemo every 3 weeks for at least a year. And again, some studies show that they need doxorubicin for that long-term survival, but again, it's still debatable. Again, overall response rates for these two protocols of about 50 to 80%, lower than dogs. Okay. We talked about the median remission and the median survival time already. Again, cats that get into complete remission is so important. Another option, so what if you have owners that don't want to come in that often, need to save a little bit more money? You can use oral lomustine in kitties. So in cats, they only get this every 5 to 6 weeks because of the side effects. We definitely use lower dosages than we use in dogs. And based on a new study, it does look like a reasonable alternative option for cats with lymphoma. Single agent doxorubicin, remember Miles, the cute basset? I said a doxorubicin as a single agent was my favorite second protocol in dogs, not in cats. They do pretty crappy. So again, another example where cats are not small dogs. All right. Lomustine, this was that new study that it just came out. It was 32 cats, only intermediate and large cell lymphoma, so we learned our lesson. The cats, the median dose was actually quite low, and it has to do with the pill sizes and sort of finding the right dose for your kitty. The majority of kitties got 1 10 milligram capsule. Most of the cats were on steroids, no surprise. About half the cats got neutropenic. None of them got hospitalized for side effects. Nobody got septic, no GI toxicity that caused a delay or change in dose for these kitties. And they saw about a 50% response rate. Again, only 22% achieved complete remission, but as a plan B, plan C option, I think it's a nice option. The median response was 10 months, so not bad. And with a range from 2 months to 4 years in the 32 kitties. Progression-free interval, so when did they start to see progressive signs or disease in these cats was 4 months, but again, quite a decent range. Median survival time was pretty short, of just under 4 months. But again, a nice plan B or plan C protocol. Well tolerated, 66% of the cats had stable disease, and it's pretty cheap and it's easy to give. Again, it's oral chemotherapy, so you don't need all of the closed system, all of the gowns and hoods and things like that for chemotherapy. So it's a good option for owners who are looking for something different. What was prognostic in this study? Cats that weren't eating well at the time of presentation, cats who were anemic, and cats that got lower dosages. So those were things that were negative predictors for these cats. So think about that when you're dosing, that lower doses could be associated with a worse prognosis. Again, don't treat cats like small dogs. They tend to tolerate chemo much better. I find that most cats do not need oral Serenian after doxorubicin like dogs, but I will send them home with it. Cardiotoxicity, dilated cardiomyopathy, is an uncommon side effect associated with doxo in dogs, not reported in cats. I usually use a lower dose in cats than dogs at a mg per kg. You'll also see 20 to 25 mg per meter squared in some references. Can worsen pre-existing renal disease, so keep an eye on those kidney values and the urine-specific gravity. Okay. Sterile hemorrhagic cystitis, we talked about this morning, pretty uncommon in cats. I don't use furosemide when I use cyclophosphamide, which is one of the important drugs in the protocol. It has not been associated with multi-drug resistance using steroids. So this is one, if you get all your diagnostics and the owner can't come see me for 10 days to start chemo, I'm more than happy to start the cat on prednisolone. I like prednisolone. It doesn't require activation in the liver. Some cats, it's estimated 50% of the cats can't activate pred to prednisolone. So I use prednisolone. There are definitely internists and other oncologists that like pred, but I usually use prednisolone in kitties. For the type 2 kitties, they usually don't require the less aggressive chemo. So think about Sophie, the kitty yesterday, where she was on oral Leukeran, and prednisone is her maintenance protocol. That's usually the standard protocol for cats with low grade, the type 2 lymphoma. There's a couple of different dosing schemes published. I like the one that's coming up in the bottom, where if they're a bigger kitty, they start with 1 pill every other day, and their maintenance is going to be every 3rd day. If there are smaller kitties, so remember Sophie was she was like 2.9 kgs when she first came in. She started every 3rd day, went to every 4th day. When she gained a lot of weight back. When she went over 4 kgs, I actually made her maintenance went from every 4th day up to every 3 days. So that's not uncommon in these cats. As they're gaining weight, that you'll have to increase their maintenance dose. So that's the dose that I like, but again, some other people use this pulse dosing. So for prednisolone, I usually start them at 2 mg per kg daily, and we'll try to back them off. I did mention yesterday that in general, I used to, because I made one cat a diabetic, which was horrible. The owner is not happy with that. I did try to wean more cats off, but I found as I got them off prednisolone, their clinical signs were, and they had weight loss. So I usually try to keep them on, like sometimes they'll be on 5 milligrams every other day. So I try to get them on the lowest possible dose. When these kitties with low-grade lymphoma relapse, we usually just sort of start using some of the bigger gun drugs. So cyclophosphamide, lomustine, vinblastine has been reported as well. If they get severe or refractory, a lot of these kitties with low-grade lymphoma, they either get resistant or they can actually transform and become high-grade lymphomas, and those are the kitties that I'll switch to CHOP or COP. You remember my kitty Jeter, after he was failing Leukeran, we started CHOP chemotherapy in him to see if that would help. Yep.
So you say relapse, do you do new FNAs to know what you're treating?
Depends. Ideally, yes, we do. The hard part for the cats that have low grade, where the intestines are just thickened and maybe the lymph nodes, or usually cytology is not going to be diagnostic, and a lot of those owners don't want to go back and do surgery at that point. And so sort of the debate that we have is, well, whether it's resistant to the current therapy or progress to high grade, you need to step up your chemotherapy anyway. I would love to be able, but the ones where I've said, hey, let's go back and do surgery and get biopsies, most owners don't want to do that. So we just treat it as refractory, or, and you can just see, if they've been on Leukeran, if I feel like it's probably low grade, I usually will do lomustine next. But if they're really getting sick very dramatically, I'll often start to do a COP or a CHOP chemotherapy protocol. Ideal world, we would definitely get biopsies. The other thing is to remember nutrition in these guys. Many of these kitties, especially our low-grade lymphoma kitties, they have concurrent inflammatory bowel disease. So we talked about this with my own cat. We switched him to a novel protein diet. I want to remember that these kitties should go on probiotics, and I like to measure their B12 levels and supplement them as needed with vitamin B12. IBD is going to be very similar. They're going to do elimination diets or a low residue, highly digestible diet, and then internists actually tend to use higher doses of prednisolone to start. This is from Frederick Gashin at Louisiana State. He gave me this. So usually they start with steroids, they're going to taper them off, then they'll add chlorambucil. I don't personally use cyclosporin, but it's one of the other treatment recommendations for kitties with inflammatory bowel disease. The other thing is a lot of these kitties do have bacterial overgrowth and will benefit from a course of antimicrobials, and so that is often used by the internist in the beginning as well. What about compounding supplementation? How common is it for these kitties to be hypobowelonemic? And the literature gives a wide range, but we know it plays an important role in the metabolism, and often it will be a vicious cycle. So a lot of these kitties, if they are hypobowelonemic, they won't be gaining weight until we get them supplemented. There's two schools of thoughts. I know some people that just supplement all cats. I like to measure their levels. Texas A&M runs the test pretty cost effectively, and so I will supplement their levels if they have low vitamin B12. It's usually weekly for 6 weeks, then another dose at a month, and then we recheck their levels. Some cats will normalize, and then some cats will stay on monthly, but most cats will usually normalize after that initial course. We talked about the microbiome, so I don't have to spend too much time. But again, thinking about the role of the microbiome, both in inflammatory bowel disease and in cats with lymphoma, I really want to make sure that our kitties are on probiotics as part of their protocol. We went through this study, but this one was the one where the cats that did not improve on conventional therapy did improve once they got a 3-week course of Proviable. So again, I really have made this part of their protocol for my low-grade lymphoma and even my high-grade lymphoma cases as well. Okay. So prognosis. As I mentioned, the prognosis for cats with lymphoma is a little bit more frustrating than dogs. Kind of how I think about cats. They're not as easily trained as dogs, and so they don't respond as easier. They kind of do their own thing. So what is prognostic for cats? What is not prognostic? Notice in dogs, remember in dogs I told you the staging system, the 1, 2, 3, 4, 5, A, B? Didn't even tell you about it, because it's not prognostic. I memorized it for boards and quickly forgot it. There is one recent paper where stage was prognostic, but in general, not that important. B versus T, in general, not considered to be an important prognostic factor for cats. Some new studies looking at it, but at this point, not. Being FIV positive it's going to make you more likely to develop lymphoma, but doesn't make you less likely to respond. Age, weight, gender, not prognostic as well. What is prognostic? Location, 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 and this will be the theme in the next lecture as well. Achieving a complete remission. So the cats that tend to achieve a complete remission usually have a median survival time of a year, as opposed to the kitties that don't. Cats that are FELV positive, more likely to get lymphoma, and a negative prognostic factor, they don't live as long. Cats that are sick, vomiting, diarrhea, weight loss, those kitties tend to not do as well. Remember the paper, the hyperexia kitties, not eating as well, did not do as well. And then cats that get a multi-agent protocol, CHOP versus COP is debatable, but again, those cats tend to do better. So for the GI forms, it's really variable. For the high-grade lymphomas, again, about 50 to 80% response rates. Achieving a complete remission is important. About 15 to 25% of the cats will be alive at 2 years. But again, so usually I tell the owners when I'm in the room talking to them, there's two subset of kitties. The responders, those are usually the ones that go into complete remission, and they're going to be my long-term survivors of 1 to 2 years. But there's a subset of kitties, usually we figure out in the first month or two, that don't respond well. And those are the kitties that are not achieving complete remission, and they're the ones that bring down those median survival times and that have the shorter remission durations. For the low-grade lymphoma, usually it's harder to define remission. Often it's based on resolution of signs, so the vomiting goes away, the diarrhea goes away, they're gaining weight, they're eating well. And again, about 70 to 85% will respond for a median survival of about 2 years, so 1.5 to 2 years depending on what study you look at. So definitely, even within the GI forms, there's a lot of variation in their prognosis. So this is a really busy chart, but this is why I wanted to really highlight why I don't care as much about B versus T. So let's look at this. So cats that have small cell lymphoma tend to be T and have a good prognosis. Nasal lymphoma kitties tend to be B cell and also one of the better lymphomas to have. So again, another example of just where B versus T didn't help us. Let's look at this. So again, small cell T, good prognosis. Mediastinal tends to be T and they usually do poorly. Skin is usually T and liver is usually T cell and they usually do pretty crappy as well. Then we have our large cell B, poor unless they're a complete response, and the nasal is B and they have a good response. So again, really highlighting where I'm less concerned about V versus T and more concerned about some of the other things that we talked about. All right, so that's the take-home messages. Vomiting's not normal. Cats that don't eat well and losing weight are not normal. And really important that we as veterinarians are talking to owners, getting a good history, and then triggering an ultrasound and getting a better look at their intestines. I showed you this yesterday, but I still love this one. See, it's just harder to get cats to listen to us. All right. Just if you guys are interested, I know it's in English, but English is so common. So these are all on my website. If you go into the album section, you can and you can share them on your clinic websites. So I have a bunch for each tumor type, but again, this is the one that was for cats. And you can share them on your clinics, websites, or things like that. But we have dog lymphoma, cat lymphoma, just finished up mammary tumors, dogs and cats. So there's been a lot of questions about mammary tumors in between the talks. So those are there as well. But again, if you go to the album section, you can get all of the infographics and share them either as an album. And again, this was that really popular one that owners seem to resonate well with owners. And that's it on that. So I think we will hop right into non-GI lymphoma, and then we get to eat lunch.
We have a break. It's a break now.
Oh, is there a break?
Yeah.
Oh, no. We're not breaking. No. Should I take a few questions, or should we just wait?